Hey guys, welcome back to my channel. So today we'll be doing the third part of the GIT integrated series, and the topic for today is stomach. Without further ado, let's just dive into the topic. So the most important topic in stomach is upper GI bleed, right? So we'll be looking at all the causes one by one. First is gastric ulcers, right? So for gastric ulcers, now let us go back and look at the classification, right? I've made or listed the classification separately at the end of this PDF so that it's easier to revise at the end. And talking about the gastric ulcer classification, which is the Johnson classification. So gastric ulcers are of 5 types. First is along the lesser curvature, that is at incisura, and this is the most common site, right? Second is pre-pyloric along with involvement of the first part of the duodenum. Third is pre-pyloric. Fourth is again along the lesser curvature but in the area of the body, that is type 1 will be more proximal, while type 4 will be a bit distal to it, but both are along the greater curvature, right? And the type 4 ulcer, it is the most common gastric ulcer to bleed, all right? And finally type 5 is diffuse gastric ulcer. So for management, type 1 is managed by distal gastrectomy, right? For type 2 and 3, we need to do distal gastrectomy along with vagotomy. Why? Because these are pre-pyloric or in the duodenum, so they will be associated with increased acid production, right? Hence vagotomy needs to be done, and to suppress the acid we can also give proton pump inhibitors. Then type 4 ulcers, right, there is a special procedure which is called as the Pouchet or the Sendis procedure, right? So yeah, when we talk about vagotomy, like there are 2 types of vagotomy, that can be truncal vagotomy or highly selective vagotomy. To know that, let us briefly look at the anatomy of the vagus nerve supplying the stomach, right? So it is the stomach is supplied by anterior vagal trunk and a posterior vagal trunk, right? The anterior vagal trunk, it supplies the lesser curvature, and the posterior one will supply the greater curvature, right? Now this anterior vagal trunk, it gives a motor branch to the gallbladder, and it also gives a motor branch to the pylorus, and then at the end it gives some tiny branches which are called the crow feet. The posterior trunk gives similar terminal branches which are crow feet, and it gives the criminal nerve of Gracie, right? All right. Also, the posterior trunk gives rise to the nerve of Letarget, right? Both anterior and posterior vagal trunks, they give to the nerve of Letarget, which ends in crow's feet. Okay. So what happens when we do vagotomy? So we do truncal vagotomy, that is we cut here, right? So what will happen? The motor branch to gallbladder will also be cut, and the motor branch to pylorus will also be cut. So there will be complications like GB stasis, which may lead to a stone formation, and even gastric stasis, right? Then also this nerve, which is called the criminal nerve of Gracie, right? Remember that this is the most common nerve which is left behind, hence it is known as criminal nerve of Gracie, and this is the nerve which is responsible for ulcer recurrence. This is a very important point, and remember that carefully. Okay. Highly selective truncal vagotomy is that we remove just the crow feet, right? So that these branches are safe, that is the motor branch to the gallbladder and the pylorus, and there will be lesser complications, right? Okay. Now let us look at the other causes for bleeding, but let's do some important scoring system for bleed, which is asked in almost all the exams, okay? And the most important one that you need to remember is the Forest criteria, right? It is an endoscopic criteria to see the risk of rebleeding, right? So it is of three there is three grades, that is grade 1, 2 and 3. 1A is that you will see visible spurting when you insert the endoscope. In B there will be ooze of blood, ठीक है? तो इसमें there will be spurting of blood, and here there will be just oozing of blood. 2A, there is a non-bleeding visible vessel, right? You can see the vessel, but there is no bleed. 2B, this is the one, this is asked always, okay? Remember B for black, so there will be a black adherent clot. All right, so that is 2B. C is there will be hematine spot at the base, and 3, there is no active bleed and the base is clean, right? So risk of rebleeding is given by Forest criteria. Then the other bleeding scores are the bleed criteria, right? Bleed is nothing, you just need to expand the abbreviation, right? B is ongoing bleed, L is low systolic BP, E is elevated platelet count, then another E is for erratic mental status or your altered mental status, right? And then D is for any comorbidity or disease along with it, right? Next is Rockall scoring, which you can remember by case, right? C is comorbidity, you just need to know the constituents, and even if you remember it, that's okay, but yeah. C is for comorbidity, A is for age, S is for sepsis, and E is evidence of recurrent bleed, right? Then Blatchford scoring system, it is a pre-endoscopic assessment, and for score more than 6 only intervention is required. Just remember that this is a non-endoscopic score, while these two are endoscopic score. All right, let us now look at gastric ulcers, right? So according to Johnson's classification, type 1 was along the incisura, type 4 is along the lesser curvature in the body, then type 2 and 3 is in the prepyloric region, right? And type 4 we have done, type 5 will be diffuse. So this is one cause of gastric ulcer, right? Then what are Cameron ulcers, right? They are longitudinal ulcers which are formed due to rolling hernia. And there is another type of ulcer which is the curling ulcer, which can be seen in patients of head injury, and they are mainly seen in the antrum of the stomach. Another confuser with curling is Cushing ulcer is seen with head injury, and curling ulcer is seen in patients of burns. Okay, how you can remember this is Cushing reflex we see in head injury patients, where there is increase in ICT with decrease in heart rate, right? So Cushing ulcer will be in head injury and curling ulcer will be in burns patient. Then other causes can be Menetrier's disease, which is a protein losing enteropathy, and this is also an important topic. You'll be shown a picture, right? It's a classic picture. I've included all the pictures at the end. Okay, so we'll have a look at it together. The thing you can remember is that it is associated with TGF alpha, and for management we give the drug cetuximab. Okay, cetuximab was asked as a question in INI-CT this year, so this becomes an important drug. So just remember, Menetrier's disease, okay, treatment mein you give cetuximab and do gastrectomy, right? Other cause of bleed can be a Delafoy lesion, right? It is a dilated arteriole, right? And GAVE is, which is also known as watermelon stomach, it is a dilated vein. Okay, so GAVE me you have V, so that is a venule, and so Delafoy will be artery. Okay, Delafoy and GAVE, Delafoy is arteriole and GAVE is a venule, right? Then the most important cause of upper GI hemorrhage are esophageal varices, right? For esophageal varices, just remember the name, Baveno classification is done, right? And we can see it in a portal hypertensive patient that presents with a variceal bleed. All right, so what is portal hypertension? When the hepatic venous pressure gradient is more than 10 mm Hg, right? Then it is portal hypertension, and at pressures more than 12 mm Hg, we will also see variceal bleed in this patient. And the causes can be extrahepatic and intrahepatic. The extrahepatic causes are EHPVO, that is the extrahepatic portal venous obstruction, right? Cavernous change. This question has also been asked in NEET 21, right? Then sinistral portal hypertension, which is nothing but a left-sided portal hypertension, right? And in these cases, the management is splenectomy. The intrahepatic causes are further divided into pre-sinusoidal, sinusoidal, and post-sinusoidal. The pre-sinusoidal are non-cirrhotic portal fibrosis. This was also asked as an option in NEET 21, I think, but some recent exam only. And the only management for NCPF is liver transplantation. Then sinusoidal causes include all the causes of cirrhosis, like cirrhosis post chronic hepatitis or hemochromatosis, Wilson, and so on. And post sinusoidal causes will be Budd-Chiari syndrome, right, constrictive pericarditis, and other causes which are associated with conditions of heart failure, like tricuspid regurgitation, right, and that causes back pressure on the liver. Then how do we manage it, right? So first of all, we do, if a patient comes with upper GI hemorrhage, then we do endoscopy, right? So they ask, what is the next step? So answer will be endoscopy. If endoscopy fails, then we will go for another attempt of endoscopy. Only after 2 failed attempts of endoscopy, then only surgery will be performed, right? This is an important thing. Remember that, because next step or the best management or what will you do next, questions like this are now the new trend in the paper that is being asked, right? Now, how we manage? We give the patient IV terlipressin and octreotide. Octreotide was also asked again this year in NEET PG, right? Then after giving the drugs, we do endoscopy, and the treatment of choice is sclerotherapy more than band ligation, right? Now then we assess the bleeding, that whether it has stopped or it is continuing. If the bleeding stops, then nothing has to be done, just monitor for 24 hours, and we give primary prophylaxis with propranolol. While if the bleeding is still present, then the second round of endoscopy is done, right? And we can use some devices like the Sangstern Blackmore balloon, Minnesota tube, and the Linton tube. Listen, these devices, they are just temporary method, or you can say they are bridge methods to stop the bleeding, right, till the patient is transferred to surgery and a definitive procedure like STIPS can be performed. So these are never the definitive management, right? So if suppose next year or in INICT they ask that what is the best step, or what is the best step for a patient with failed UGI, then you will say surgery, which is TIPS. But if they ask what is the next step, right, after 2 failed attempts, so the answer will be using a balloon device. Okay, now what you need to remember is that the Sangstern Blackmore balloon, the capacity is 300 ml and it should be deflated every 12 hours, right? These are also important points because questions on them have been asked. Like the trend is now changing from single one-liners to questions that require you to think a bit. Okay, right. So what is TIPS? TIPS is transhepatic intraportal transhepatic intraportal portosystemic shunt, right? And the most common complication of TIPS would be encephalopathy, which is an early complication, while late complication, right, remember whenever there is a stent or a tube, anything, it is either migration or block. So here there can be blockage of the stent. Okay. So what they do is that, suppose this is the hepatic vein, right? This is the right hepatic vein and this is the right portal vein. So they insert a stent through the IJV, then to IVC, and then to the right hepatic vein, and then they from the right hepatic vein they make anastomosis to the right portal vein, right? So this is the path of the stent and it connects the right hepatic vein and the right portal vein. So what it does is that it decompresses the portal vein and the portal hypertension is resolved, and since the portal hypertension is not there, there will be no chances of bleeding, right? Other types of shunt are Linton shunt, Mitra shunt, and ECK shunt. You can just read about this, not very important to learn. They can be asked as options, right? But you just need to know the names and just have a look at this. Like this is a end to side anastomosis, this is the side to side anastomosis, right? But these are all proximal shunts. And some other shunts are like Warren shunt, Inoguchi stent, etc., right? Don't remember these names, just you should know it, because if you read it once, then it's easy to eliminate in the options when you are confused with two options or stuff like that. They will never ask a direct question on this, they will just help you to eliminate the other options, right? Now if TIPS also fails, then we do Seguera procedure, right, which is devascularization of lower 6 centimeter of esophagus, right? So let us revise it. So what we will do, the first would be endoscopy, okay? If it fails, then again endoscopy. If it fails, then we will put balloons like Sengsten Blackmore till the patient is transferred for a definitive surgery, and the best management would be TIPS, right? Wait, here if the second endoscopy fails, we will go in for surgery such as sclerotherapy and banding, right? If this fails, then we will go for balloon and TIPS. And if nothing works, then what we will do, Seguera procedure, which is nothing but devascularization of lower 1/3 of lower 6 centimeters of esophagus, right? Now in lower GI hemorrhage, if they ask, the investigation would be a colonoscopy. If colonoscopy is positive, then the vessel is cauterized. If it is negative, then it is suggestive of an upper GI hemorrhage. And again, the next investigation would be an upper GI endoscopy, right? If we can see a bleeding on upper GI endoscopy, it is called as upper GI hemorrhage. If it is negative, then the term is called as obscure GI hemorrhage. So what is obscure GI hemorrhage is that if it is colonoscopic and upper GI endoscopic negative bleed, right? The causes are mesenteric, the investigation that we will do are mesenteric angiography, capsule endoscopy, and a technetium-99 per technate scan, right? This is important. It can be used in case of obscure GI bleeding, right? Now let us look at the blood supply of the stomach. So the stomach is supplied by the lesser gastric artery, which is a branch of the celiac trunk, right? And the right gastric artery, which is again a branch of celiac trunk, but not a direct branch of the celiac trunk. It is a branch of the common hepatic artery, right? The right gastric artery. Then the greater curvature is supplied by the right gastroepiploic artery, which is a branch of gastroduodenal artery, and gastroduodenal artery is again a branch of common hepatic artery, okay? And the right gastric artery, it is a branch of common hepatic artery. So the common hepatic artery basically would give rise to hepatic artery, right gastric artery, and gastroduodenal artery, okay? This is celiac trunk. It has 3 branches. Let us do it quickly, the celiac trunk, okay? Because they ask questions. So this is the celiac trunk. It arises at the level of T12. The branches are, first is a splenic branch, right? It will give rise to short gastric artery. Next, it gives left gastric artery and hepatic artery proper. Hepatic artery proper gives rise to right gastric artery, gastroduodenal artery, and hepatic artery common, and then hepatic artery proper, okay? Hepatic artery proper will divide into right hepatic artery and left hepatic artery. Then gastroduodenal, it gives rise to the right gastroepiploic artery, and the left gastric epiploic artery is a branch of splenic artery. Okay. And this gastroduodenal artery, it continues as superior pancreaticoduodenal artery. Okay. Now from this, remember that inferior pancreaticoduodenal artery, this is a branch of superior mesenteric artery. Okay. Superior mesenteric artery arises at the level of L1 and inferior mesenteric artery arises at the level of L3. So just remember one more question, कि a horseshoe kidney, right, which is nothing but a kidney fused at the midline, is not able to ascend upwards due to the presence of IMA, hence its ascent stops at L3 level. So right, see how many questions are done from this small diagram. So yeah, basics should always be clear, right? So the next important topic that we need to know in stomach is gastric cancer, right? So the classification is Lawrence classification, Japanese classification, and the Borman classification, right? The Japanese classification, the gastric cancer is of two types: early gastric cancer, which is type 1, and the advanced gastric cancer, which is type 4. And in advance, we can see linitis plastica, that is nothing but a leather bottle appearance of a stomach, because there is so much fibrosis, right, that the stomach shrinks and is shriveled up, and it looks like a leather bottle, and it has the worst prognosis, right? And what is most important is the atypical presentation of gastric cancer, right? So let us go through them. First is the Blummer's shelf nodule, which is lymph node in the pouch of Douglas. Second is the Virchow's lymph node, which is also known as Strohizier's sign. It is in the left supraclavicular region, right? So this is clavicle. So this is right, left. Okay. We always see the right of the patient, because we assume that he is standing in front of us, and therefore remember that this should always be taken as right and left. Okay, this is the standard, and you will never make a mistake even when you see a CT or any cross-sectional imaging. Okay, so this is left. Let us do. The left supraclavicular lymph node is the Virchow's lymph node. Then the lymph node in the pouch of Douglas, it will be Plummer's shelf, right? Third is the Irish nodule, which is left axillary. Okay, this is left axillary. This is Irish. Then Sister Mary Joseph nodule, it is in the periumbilical region, right? Sister Mary Joseph was a nurse who first pointed out to the doctor that the patients with the gastric cancer always have a node in the periumbilical region, so this node is named after her. Then Krukenberg tumor, it is the Mets due to bilateral ovarian cancer, and if you need to choose one best answer, then retrograde lymphatic spread more than transcoelomic spread is the route of metastasis. Then some signs, right? Troju sign, it is migratory thrombophlebitis, and it is also seen with other adenocarcinomas, right? These are basically signs of adenocarcinoma. Then lesser Trelat sign, there are multiple seborrheic keratosis and trypans, which is the hyperkeratosis of the palms. Okay, these are very important. This whole thing is very important. This is tested in one form or the other, and this should be on the tips, fingertips, like ratta maro wali cheez. Okay. Next is GIST, right? It is the most common mesenchymal tumor. There was this one question, it's a previous year question only, that the most common epithelial tumor is adenocarcinoma, and the most common mesenchymal tumor is GIST, right? For GIST, the investigation of choice is CECT, and sporadic is most common, right? Then there is Carney's triad. Remember, it is associated with SDH mutation, right? In familial cases, there will be Carney-Stratasky syndrome. What is the difference? So in Carney's triad, there would be GIST, pulmonary hamartoma or chondroma, pulmonary chondroma basically, right? And third would be a paraganglioma. While in Carney-Stratasky syndrome, there would be only presence of a GIST along with a paraganglioma, right? For GIST, the classification is the Fletcher classification, right? And the most common mutation is CD17 or c-KIT mutation, and the most specific, if you ask, is the DOG1 mutation. CD34 is also associated with it. For management, a 2 centimeter margin is required for clearance, and wedge resection is done. Then imatinib is given because it is imatinib sensitive tumor. Remember that SDH mutated GISTs are imatinib resistant. Okay, important question. And if the tumor is resistant to imatinib, what we will give? Sunitinib. Okay, anti-cancer drug is very important for the central institutes. I cannot stress upon its importance basically, because like there were so many questions this year in INICT from just anti-cancer drugs, like nothing but just the names, right? So yeah. Then the third type of cancer is a lymphoma, and the management is chemotherapy followed by surgery, because it is chemosensitive tumor. And this is a very famous question. R-CHOP regime is done for lymphoma. Again, it is a question of the anti-cancer drugs. What is R-CHOP? It is rituximab. This is a CD20 inhibitor, right? Cyclophosphamide is an alkylating agent, right? That leads to the formation of DNA adducts and improper DNA formation, right? Then hydroxydanorubicin, it is an anthracycline, and remember the question that is asked with anthracyclines is that they have cardiotoxic effect and they affect the heart, right, causing DCMP, and it is treated by giving desferoxamine, because desferoxamine is an iron chelator. Desferoxamine, right? So the heart failure is due to increase in iron, and this will chelate the iron, and it helps in management, right? This is extra, wild thoughts running wild type of a question, right? Then O is for oncobin, right? Oncobin is vincristine, right? And then prednisolone, everyone knows it is a steroid, right? Then another important question, this hasn't been asked in the recent exams, but this used to be an important question, and we'll just go through it quickly, right? The gastric reconstruction procedure. Why? Because a lot of people are going in for laparoscopic surgeries or bariatric surgeries for weight management, and therefore it is being practiced widely in all the metropolitan cities and in the private hospitals, right? So yeah, I'm sorry, I just forgot to show you the images, right? So GIST, right? So how will it appear on the CT? This is a stomach. Okay, so stomach say it will be protruding out. So this is a GIST. This is a very classical diagnosis of GIST on CT, right? You can see it, make it here. This small thing here, which is an exophytic growth, right? This is GIST. And the histopath image, right? So on histopath, what will we see are these long elongated cells, right? They are called as spindle cells, and they have eosinophilic cytoplasm, right? And also we can see some mitotic figures as well, right? So based upon the number of mitotic figures, it is classified as a benign GIST or the typical GIST, and an atypical GIST or a malignant GIST, right? Mostly they are benign only. Okay, now let us get back to the gastric reconstruction procedures. So first is Billroth 1, right? Billroth 1 is nothing but what we do is that we perform a distal gastrectomy, okay, and then an end-to-end anastomosis is done between the duodenum and the stomach, which is known as the gastroduodenal anastomosis. Then Billroth 2, it is just like a polya reconstruction. Here, like the body and the antrum is removed, right, and there is end to side gastrojejunal-anastomosis. Okay, so this is removed, right, and the jejunum is anastomosed with the stomach, and the duodenal stump is just sutured or closed. Then the third type is a Roux-en-Y gastrojejunostomy. Here again, a large part of the stomach is removed, right, and then the duodenum is cut, the cut end of the duodenum is sutured, and at end to side gastrojejunostomy is performed again, right. So the limb, right, so just imagine like this is stomach, okay, this is the duodenum, this is the small jejunum, sorry, stomach, duodenum and jejunum, okay. So what do is that duodenum is sutured, this is the duodenum, and it will have the bile, so it is called as a biliopancreatic limb, okay, which is 50 centimeter from the DJ flexure, okay. After that the limb is known as the Roux limb, right, and the length of the Roux limb is inversely proportional to the weight loss. Suppose if this is 100 centimeter and weight loss is X, for a 200 centimeter limb the weight lost would be lesser, like less than X, ठीक है. तो बेसिकली द थिंग इज़ कि ये जितना छोटा होगा उतना देर विल बी लेस अब्जॉर्प्शन, और लेस अब्जॉर्प्शन मीन्स देर विल बी इंक्रीज्ड gastric transit time, increased transit time, and the food will not stay here, it will move quickly to the next portion and it will not get absorbed and it will lead to weight loss, okay. Now how do we anastomosis that? We do gastrojejunostomy, right, end to side or end to end jejunostomy, okay. Now what are the complications of this? That there are two limbs. First, they can be an anticolic or they can be a retrocolic limb. What does this means? So suppose like this is a transverse colon, okay. What happens is that this is duodenum, this is jejunum normally, and here like this. So when we do an anastomosis, what we do is we take this limb, right, and we tie it to the stomach, we anastomose with the stomach. Now this can either pass in front of the transverse colon, which is called as anticolic, or we can make it pass behind it, which is called the retrocolic limb, okay. The problem is that with anticolic limb there is chances of Peterson hernia, right, that is between the transverse colon and the limb, and retrocolic there is chances of Stemmer's hernia, right, because through the transverse mesocolic window, okay. So here we will have Stemmer's and इसके साथ we will have Peterson, ठीक है. R and S पास में आते हैं तो retrocolic Stemmer's hernia, just remember that, ठीक है. What can be the complications? The most common is iron deficiency anemia, because obviously there is shortening of the limb. Then one important complication on post-op day 4 is a stump blowout, ठीक है. Then another on which you are frequently tested is the dumping syndrome, which is of two types, early or a late dumping. In early dumping, there is it happens due to presence of hyperosmolar substances, right, and it can be seen within 10 minutes for up to 30 to 40 minutes postpartum, right. Late, it is due to rebound hypoglycemia. Why? Because due to increase in insulin there is rebound hypoglycemia, and this will be seen after exercise, like usually 45 to 1 hour after exercise, ठीक है. So the management is again octreotide, ठीक है. Octreotide was recently asked. I told you that whatever is recently asked becomes an important question along with the topic that it is associated with. So again, for management, what we give is octreotide, and again the surgery that is done is Roux-en-Y gastrojejunostomy to prevent this complication. Alright, so this was stomach. One more thing before wrapping it up is the histological appearances of adenocarcinoma and diffuse gastric cancer. Okay, remember from the classification, this was type 1, this is type 4, and this can lead to linitis plastica. Okay, yeah. So adenocarcinoma, on histology we can see there is glands. Okay, so this is adenocarcinoma. What they will ask you is the diffuse carcinoma, right? Here you can see the signet ring cells, cell with an eccentric nucleus. Okay, signet ring cells are also seen with Krukenberg tumor. Yeah. So one more thing which you need to know is that if there is a beta catenin mutation, right, so this will be associated with loss of E-cadherin, and the histopath would show Indian file pattern. Indian file pattern is also seen as lobular breast cancer, right? So yeah, this was like the most important part in stomach. In next class we'll be doing the intestine and wrapping up with the classifications as well. And yeah, so this is all we have to cover in the next class. And intestine along with the anal canal is very important, and I think this is the most important part of GIT, right? Thank you for listening. Bye bye. Like, comment and subscribe, and do visit my Instagram channel if you want a PDF of this copy. Bye bye. Happy learning.